Today, I'm going to talk about the controversies in the displaced scaphoid fracture management. And I hope that at the end of my presentation, you will be convinced by me that conservative treatment is a better option. So scaphoid fracture is the most common carpal fractures, and the indications for surgery include the following: perilunate fracture dislocation, displaced or comminuted fracture, established non-union, and proximal pole fracture. But today we are going to talk about the type B2 fracture, which is undisplaced, meaning which is less than 1 millimeter step or gap. Whether to treat this conservatively or surgically is controversial. Conservative treatment means cast immobilization, whether using a long arm or short arm cast, with or without thumb immobilization. According to the systematic review, there's insufficient evidence to confirm which type of cast is superior. How about surgical treatment? The current trend is by using a percutaneous screw fixation, either in a retrograde or antegrade manner, and the obvious benefit is earlier return to work and earlier return to sports. And Dr. Jeff Ecker will further elaborate this in his lecture. So, whether to treat conservatively or surgically, what is your choice? So let's take a look at this scenario. So if one day you had a fall injury and sustained an undisplaced scaphoid fracture in your dominant hand, what would you choose? Will you choose conservative treatment or percutaneous screw fixation? So I asked this question by sending a questionnaire to 100 healthcare workers and asked them if they sustained such a fracture, what would they choose? And there are 56 respondents, and 66.1% responded they will choose surgical treatment, while 32% will choose conservative treatment. So I further analyzed the factors to see which factor actually will contribute to the treatment options. So concerning the age is not a significant factor that affects the treatment of choice. Gender is also not affecting the treatment of choice. For occupation, there's no significant contributing factor that affect the treatment of choice. But interestingly, when I further stratified the occupations into male and female, I found that male orthopedic non-hand surgeons preferred surgical treatment, while female hand surgeons prefer conservative treatment. Whether you are active in sports seems there's no affecting the treatment options, and whether you're actively playing any musical instrument also is not a significant factor that affect the treatment options. So is there any evidence to support screw fixation or conservative treatment? So a systematic review in 2016 shows that screw fixation has a faster return to work and shorter time to union, but conservative treatment has a lower complication rate. Another meta-analysis in 2018 shows that screw fixation has a faster return to work and shorter time to union, but concerning the function, range of motion, and complication, there's not much difference. So the conclusion of these two systematic reviews is that evidence is insufficient to conclude that surgery is a better option. Let's take a look at more studies. Concerning the return to work, surgery has a faster return to work at 6 weeks, while conservative treatment takes 11.5 weeks. Range of motion, at 8 to 16 weeks, screw fixation has a better range of motion. But after that, there's no difference, or even there's a better range of motion in the conservative treatment group. For grip strength, from 8 to 16 weeks, screw fixation has a better strength, but after 16 weeks, there's no difference. Similarly, for function score, at 8 to 12 weeks, the function score is better in the surgical group, but after a year, there's no difference. For the time to union, it seems that screw fixation has a better time to union at 7.4 weeks. However, it is just 2.8 weeks difference, and this is also related to whether you look at it at a CT scan or you look at it at just radiographs. For non-union rate, there's no difference between the two groups. For the complication rate, conservative treatment has a much lower complication rate, and more importantly is that surgical complications are usually more serious, and I will further elaborate on this. Concerning arthritis, conservative treatment has a much lower risk of arthritis. So radiation exposure is a major drawback of surgical treatment because it is not uncommon that you need to take quite a lot of X-rays in order to put in a screw in a good position. Concerning the cost, conservative treatment, the cost for the direct cost, which is the cast, is $650. And for screw fixation, the cost is $7,500. So concerning the indirect cost, which is the salary of the patient absent from work, and if you add these two costs together, screw fixation is much more expensive. For surgical complications, it can be classified into implant-related complications, tendon, nerve, and vascular injuries. Implant-related complications include broken drill bits, guide pins, or other broken implants, and also protrusion of screw. Either the screw head or even the screw tips can be protruded out. And this one study shows that actually these complications are not uncommon. There's up to 12.5% of screw impingement or protrusion, and 8% of cases has implant breakage. For tendon injury, if you go to the volar approach, rupture of the FCR tendon has been reported by a protruded screw head, and FCR tendon injury has been reported as high as 27% of cases. On the dorsal approach, there's 12.5% risk of injury to the extensor tendons. Nerve injury is also reported, with one case of compression of the median nerve by the screw being misplaced volarly. For vascular injury, if you go to the volar approach, the superficial palmar branch of the radial artery is at risk. So I will show you a real example. A 28-year-old gentleman, right-handed IT worker, come to my clinic, and he sustained a right scaphoid fracture, undisplaced. So I asked, do you want surgery? You can return to work early, but there are risks of surgery. And he replied, no, doctor, please, just give me a cast. So he explained that that was what happened to him 2 years ago on the other side. So there's protrusion of screw and complications, and therefore, for this time on his right hand, he chose conservative treatment. And at 8 weeks, the fracture healed well and he is happy. So in conclusion, for undisplaced scaphoid fracture, surgical treatment has a faster return to work at 6 weeks. Concerning the range of motion and grip strength, it seems that there's not much benefit for surgical treatment, only in the early postoperative period. Union rate 7 weeks versus 10 weeks, I think there's not much benefit for surgical treatment. But conservative treatment has no radiation, no surgical complications, and a much lower rate of arthritis in the long run. So I think conservative treatment is a better option for this type of scaphoid fracture. So thank you very much.